Welcome to HUMED. My name is Dr. David Spiro. I'm a pediatric ER physician at Arkansas Children's Hospital, professor at UAMS, and I'm incredibly delighted today to be hosting one of my colleagues, Dr. Abby Nolder. For those of you who are first-time listeners, welcome. This is a show around human medicine and the human side of medicine. I think that all of us who practice medicine, whatever our specialties are, have a story to tell. What the human side of medicine is, how stories affect us, and how we approach the way we care for patients on a different level than just making the diagnosis or, in Dr. Nolder's case, sometimes operating. So with that, I'll turn it over to Dr. Nolder. Can you tell us a little bit about how you got here today, what you do at Arkansas Children's and UAMS, and how you became an ENT surgeon?
Yeah, sure. First of all, thanks for having me on. I'm happy to be part of this and share our stories. I'm a pediatric otolaryngologist at Arkansas Children's Hospital. I have been there on faculty since 2012. I went to medical school at UAMS in Little Rock and then did my residency there as well. And then decided during my third year of otolaryngology residency that I wanted to devote my career to pediatrics. So I did a fellowship in pediatric otolaryngology at KU Medical Center and Children's Mercy Hospital in Kansas City, and then had an opportunity to come back to Arkansas Children's on staff, and I took that opportunity. So been caring for kids for going on 13 years. I have double board certification in both otolaryngology, head and neck surgery, and complex pediatric otolaryngology. And yeah, you and I have worked together on some, committees and things like that, and working, taking care of patients in the ER, and for me from a consultant, and you as a physician there. So happy to be part of the podcast.
Tell me a little bit about a story, because I just for the audience to know, I don't hear about the story, or this is very unplanned and unscripted intentionally, and because I want to be excited about hearing the story too as a first-time listener. And it's what's interesting, Abby, is that almost everyone I've asked to be a part of the HUMED journey, when I ask someone, "Do you have a story?" and almost the immediate answer is, "Yes, I have a story to tell." So I've been anticipating your story, so please share.
Yeah, isn't that interesting? Yeah, when you told me about the podcast and that it was, what I took from your prompt was, a patient that impacted you in some sort of way. I told you, the bad news is the story that I have to tell doesn't have a happy ending, but I think there's a lot to be learned from it. Just as surgeons, we want to help people, but we know that there's also, potential for harm there. And you know, it's not always, the happiest outcome, but so my story, it happened early in my career. I as a pediatric otolaryngologist, we do a lot of complex airway surgeries and complex airway reconstructions. The patient that came to mind is a child that I really carry with me every day and has really kind of impacted the way I take care of patients and approach families. And she was born severely premature, so was in the neonatal intensive care unit, and that was where my first contact with her and her family. And for those that may not be familiar with medicine, so extreme prematurity comes with a lot of issues. The lungs are not fully developed, so they often need ventilator management to be able to breathe. And that combined with a very small airway, sometimes they'll develop airway, scarring and stenosis. And that's how I came to know this patient. They had trouble getting her off of ventilatory support because her airway was small and she had developed some scarring.
And Abby's, there will be some folks listening here that are not physicians, or maybe they may be learners. So when you talk about
Mhm.
ventilatory support, can you share a little bit what you mean by that?
Yeah. So when babies are born very prematurely, their lungs aren't fully developed and they have difficulty breathing on their own.
Mm.
So that requires placement of a breathing tube or endotracheal tube into the baby, and then connecting that to a ventilator to where the ventilator will provide breaths for the child. And sometimes, like in this patient's case, they require that for several months at a time, because this baby was born at 25 weeks, and normal, a not premature would be up to 40 weeks. So it may be, several months that they need this, breathing support before they can, breathe on their own. And there are a lot of things that go into them being able to remove that support. They have to be able to breathe on their own just from a, lung perspective. And then they have to be able to kind of maintain their airway on their own. And the issue that this child had was being able to, when they tried to take the breathing tube out, she was not able to breathe on her own. And so I was consulted to figure out, is there some structural problem with the airway, with the windpipe or the vocal cords that may be preventing her from being able to breathe on her own. So that's how I came in contact with her. Yeah. Um, so, it's interesting. I remember just the very first conversations that I had, with this family. It was their first child. They had been with this baby for months in the ICU, and they call me in because the neonatologist, the specialist in the ICU, had done everything that they could do to optimize this baby to come off the ventilator. And so, I met with the family and discussed the different options. And the way that we determine if there's a problem with the airways to take the child to the operating room, take the breathing tube out, and look with special cameras and equipment and assess the size of the airway and just kind of the any kind of structural and anatomic issues. Um, and so I found that she had a very small airway, and that was preventing her from being able to breathe and support herself when she would come off the ventilator. So I did, discuss the options at that point were either to do some type of reconstruction where you expand the airway and make it bigger, or to place a tracheostomy tube, which would be a tube that's placed in the neck to kind of bypass the narrow area. And then discussing with the family, we decided to do an airway reconstruction to make the airway bigger. We did that. Surgery went great. Increased the size of the airway. Several weeks later, unfortunately, she was still not able to come off the ventilator because of some needs from her lungs and from the prematurity. So we did subsequently end up needing to do a tracheostomy. So um, took baby back to the operating room after several different contacts with the family and trips to the operating room. Decided to place a tracheostomy, and that would allow the baby to be able to go home and still um, use the ventilator for breathing, but at home. Um, if you can imagine anyone that has children, taking care of a baby in general, plus a baby with premature medical problems and a tracheostomy and a ventilator, huge, training process that goes in with families, huge, lifestyle change for them. We were able to get all of that done, and she was able to go home with her family. And so the next step when the child has the tracheostomy, you have to wait until they're off the ventilator, so able to breathe on their own. Um, and then hopefully the goal is to get the tracheostomy tube out. Um, so, by this point, I've spent 2 years with this family watching them grow. Mom subsequently got pregnant and ready to have another baby, and this premature baby that is beating all the odds. We're watching her grow and develop and meet all these milestones. And so we start talking about what do we need to do now that she's off the ventilator to get her tracheostomy tube out so she can live life like a quote unquote normal child. So we start talking about the steps that need to be done for that. And unfortunately, as she grew, the initial airway reconstruction was still not, her airway still was not big enough to support her for the tracheostomy tube to come out. Um, so she needed another surgery, a different, more extensive airway reconstructive surgery, where we actually take part of the rib cartilage and carve it to make a graft to expand the airway both in the front and the back. And the first surgery that she had, she was way too young to use ribs, so we had to use part of her voice box here, and it only expanded a little bit, which, I mean, the graft that we end up taking is about the size of a grain of rice. I mean, this is really tiny airways we're talking about. But then when she was bigger, we had, opportunity to do, another surgery to finally, hopefully open everything up and get her a chance to get her tracheostomy tube out. So we did all of that. She did great, healed from that surgery. And there was one last step that we needed to do to get the tube out. And this kind of brings up another thing. So, in order to, show that the child is able to breathe without the tube, we put a cap on the trach, and that would mean that she can breathe in and out without needing the trach tube. And then we get a sleep study. So basically, watch the child sleep with the tracheostomy tube capped, and if they pass that, then trach comes out. Well, unfortunately, she had a little bit of what we call obstructive sleep apnea, which is really common in kids and adults. But in kids, the main issue with that usually is that the tonsils in the back of the throat or the adenoids in the back of the nose are too big. Um, so the next step was to remove her tonsils and adenoids and hopefully address the obstructive sleep apnea, all with the plans to get the tracheostomy tube out once she's all healed from that.
And obstructive sleep apnea meaning while she's asleep, there are brief periods of time where she just stops breathing.
Correct. Or there's just a decrease in airflow. So we want, 100% flow. A lot of times there may be 50% flow. So we just basically want to open the airways up to where she can have maximal, breathing during sleep and when awake. But yes, so that's the definition of obstructive sleep apnea. So took her to surgery, did that, removed tonsils and adenoids. Everything went great. So our goal, so by this point she's 3 years old. So I had been, with this family now for 3 years from NICU to, she's now in daycare, preschool. And our goal was to get her trach out by the time she turned 4. That was our goal. So she got through the surgery. I usually keep them out of school or daycare for 2 weeks after the tonsillectomy. She went back to daycare. It was right at that 2-week mark, and, the next contact that I had was a message in Epic, which is our medical record, from one of the physicians at, our other hospital in Northwest Arkansas. The family lived in Northwest Arkansas, telling me that, she had come in. They found her down at daycare, and she had come into the emergency department, and they were unable to revive her. Um, and so, I think this was maybe a Monday morning. I get this message, and of course, when I saw the name, I immediately knew who it was, um, and several things went through my mind. I mean, first of all, the compassion that the physician showed sending me that message, just the words that she used, were really impactful. She knew that it was, a patient that I had cared for and that I would, want to know what happened. So I appreciated that very much. If she had not, told me that, I may not have even known that this, event occurred. And, so I really appreciated that, and I kept that message in my in basket for I think it finally fell out. I mean, this has been going on 6 years now that this happened, but I kept it there. And every time I opened my in basket, I saw that name, and it was for, various reasons. I just wanted to remember her and, kinda just carry that with me, just remember, that experience that that family had. Um, and I immediately contacted, the mom, and what I learned from that is what do you say? We don't know what to say, and sometimes it's okay to just say, I don't have the words here, but I just want to know that I want you to know that, you know I'm here. I see you. We all loved this child. I mean, if you in ENT, our trach patients, I mean, just from the nurses that take care of them, the respiratory therapists, the people that train them, so many contacts just within the, physician group, the nursing group. We really, really get to know our airway patients and specifically the tracheostomy patients because they just, require so much care. And so multiple people in our clinic, knew this family and had gotten to know them. And anytime we lose a patient, it's hard, but, I mean, this was a patient that I had, had for really the first several years of early in my career, and it was really, devastating in a lot of ways, and it made me, question, it wasn't a direct she was healed from surgery, it was 2 weeks out, and it wasn't a direct surgical complication, but for the non-medical people, we do this thing called M&M conference or morbidity and mortality conference where we basically go over any case that either had, an unexpected or unanticipated outcome. But anytime a patient dies within 30 days of a operation, we look at that and to try to determine, was there something that, you know, could have been different? Could we have, any areas for opportunity or opportunities for improvement around that? And of course, as a young surgeon, I look back and I'm questioning, what is there anything I could have done differently, to change this patient's outcome? And we don't really know the specifics of what happened, whether you know was it a tracheostomy related issue. um they said they found her down and she was seizing, but she didn't have a history of seizures. So and just even having a tracheostomy, there's about a 10%, risk of mortality, really. And that goes up even higher if they require ventilatory support. So we know it's a risky thing. So the goal is to get it out. And we were, doing everything we could to get it out. And, I still wonder, had we done the order of surgeries different, or, should I have done it in a single stage rather than at a double stage, which um, not leaving the trach in, but taking it out at the time. So you just kind of question, the decisions that you make and, is there something you could have done to change the outcome? Um, I still stay in touch with that family. They are, just they have a little boy now. He's gosh, he's probably 6 now. And I keep up with them on social media, and, mom and dad were both so grateful for, everything that I did. I think as physicians, we look back and question, what we did, but I think a lot of times our families, they don't know what we know. They just know that you were there for them when you needed them, and I think they truly believe, and I did do everything that I could to help their child, and I think that's what they took away from it. And I'm really grateful for that. They now have a kind of have started a foundation in her name, to help other families that have infants with prematurity and some of the challenges that she had. So, it's made a lasting impact on me. I think about her all the time. Every time I have a difficult airway in the NICU, she just crosses my mind so many times. And I went on to do several more airway reconstruction surgeries after that. But it also kind of made me realize that um, you know I don't do as many as I did in my early career, because I get really attached to these families, and the outcomes, you know, are really not always that great. And it's really, really difficult burden to carry because as a surgeon, you want to fix things, and sometimes, the the patients, the pathology, it just doesn't lend itself to that. So, yeah, so I wanted to tell her story just for to you know, keep her name out there, and just I tell my trainees about her all the time, and I'll carry it with me my whole career.
Well, we don't know each other that well, and after you've told that story, you've touched my heart, and I feel like I know you in a different way, seriously, in a very beautiful, humanistic way. because I feel like those of us that are doing the work that we do, we we're humans. We feel things, and this story affected you. A couple questions I have. One is, when you found out about this news and the story and what had happened when the child passed away, how did you take care of yourself? Because I'm assuming you were telling the story because it moved you, and this family moved you, and it continues to move you in some way. Um, how do you take care? How did you take care of yourself um, emotionally, and how do you show up for work the next day? And sort of what was your process around this?
Yeah, that's an interesting question because a lot has happened just to me personally since that time, 2019 to now. So I may have handled it differently now than I did back then. But in medical training, they don't tell you how to do that. They don't prepare you for losing patients. They don't prepare you for the emotional impact that it's going to have, and especially in surgeons. I mean, you're expected to, uh, you know, take it and move on and not really show a lot of emotions. I mean, when I found it, because I was sitting in my office and, I cried in my office. And I talked to my nurse and let her know. And we kind of did some things together to send, flowers and, card and stuff to the patient service. But I didn't show at the time, I didn't show, the emotion. And I didn't really even share it until years later when, going through just some personal things on my own and being in therapy and things like that, that I realized that we need these trainees and just people in general. You need to show your vulnerability to show others that it's okay to be vulnerable and that it's okay that this impacts you emotionally. Um, and you can't let it, I tell my residents all the time, you can't let it paralyze you. You have to, keep moving. But it's okay to, not be okay sometimes. And I think we have to compartmentalize things to a certain degree. Because people will say, all the time, "Oh, I can't do pediatrics. It's too hard." And it is hard, but you kind of have to, you know, feel it when you can, and then, move on to the next thing. But I just help it helped me to tell her story. It helps me to tell her story still. And to, the other people that took care of her. And it helps because, they people usually say, "Well, you did everything you could." And I think, I need to hear that I did everything that I could, that this was not my fault. So, and just telling that over and over, it helped me, and staying in contact with the family, has helped too. Every year on her birthday, her mom will post something, and I always, respond to that and just let them know that, you know, that I think about her all the time and carry her with me. So, but I think keeping all of that inside, I mean, as a resident, I remember, crying in the stairwell because I didn't want anybody to think that I wasn't this, tough, surgeon. And but you can be both. And that's what I know now is that I'm both. I'm a really good surgeon. I, can do really hard things, and I can be emotional. I can be vulnerable. I can, make mistakes. That's a big thing. You can't be perfect all the time. I spent a lot of my years, chasing perfection. And when something like this happens, it's like, you know, that kind of slaps you in the face. Is like, no, this is not a perfect medicine is not perfect. Surgery is not perfect. I certainly am not perfect. And just kind of learning that it's okay and you don't have to be perfect all the time has been a huge relief for me. And I try to pass that along, to people. I see it sometimes in learners that I see some of that. I can pick up on it, and I kind of tell them, "Hey, it's okay. I've done this. I've made mistakes, and you will unfortunately." make mistakes and it may impact your patients. And it's just kind of the way that it is in medicine.
Yeah, because for those of you that are not in healthcare listening to this podcast, or if you're learning and coming into healthcare, Dr. Nolder and myself, we're considered quote on faculty. So not only are we practicing medicine and Dr. Nolder's practicing surgery, but we're also role models and teaching. And so there are multiple things happening at the same time. You know, what's interesting, you were talking about your tracheostomy patients, and I'm assuming that there are some patients that you see and you see once or twice and then you never see them again. And this sounds like a population that you really get to know the families and all the different aspects of the social side of medicine. In my field, um, I think death is hard via different lenses, and you know, my perspective, and when I often deal with death in the emergency department, thankfully it's rare, but when it does happen, I don't really know the family. And similar to you, a child will come in usually in cardiac arrest, and we have a series of protocols that we go through called Pediatric Advanced Life Support or Advanced Trauma Life Support with my surgical colleagues, and we kind of go through algorithms, and it's not robotic, but it's pretty much very formulaic and straightforward. And I kind of go into a certain mode when I'm in that realm. But then all of a sudden, when I head to the quiet room and I have to talk to the family and give families bad news, that's when I get really. That's when you realize that this child had a life, and the impact that this passing will have on the family. And uh, I, I'm going to be vulnerable as well. It's part of this show, and over the course of my 25 to 30 years of practicing medicine, I've become way more emotional in the moment, and I'm okay with it. And I will occasionally cry in the quiet rooms, giving folks bad news, and not to the point where I lose it, but to the point where I'm not afraid to show uh, my emotions. And uh, what's hard in medicine, I don't know. I'm curious about your approach to this, but you know, in my world, when I have a death in the ED, it's almost usually never at the end of my shift. So then I have to get up and see more patients who have other issues and dealing with other things and kind of move on. Um, is that the same thing in your world? I'm assuming you're in clinic or you're doing operations, and I'm assuming you just have to continue on with your day, despite
Yeah.
dealing with some tragic news that you have to give. Is that fair?
Yeah, absolutely. And I agree with you. I too have started showing more emotions as I've learned that it's okay and that families really appreciate that. I usually will start with just by saying, yeah, and even if it wasn't a death, but just, "I'm really sorry that this happened to you, and I know that this is a really stressful thing." Because I come out to talk to them after whatever surgery, like, especially, if we're dealing with traumas or things like that, I have to and I learned a lot from this situation and this family is that they're humans that are sitting in the waiting room with their child that's been in the operating room. I do this every day, so doing the surgery that I'm doing, I don't I just do the surgery that needs to be done, but I've tried to really, remember that this family is going through one of the worst things they could possibly go through, the most traumatic things. And so I usually will start by saying, I'm really sorry that this happened and this is what we've done about it and this is, how we're caring for your child. And so yeah, and I mean we'll, I often get called to, difficult airways where, a child may be, having CPR or, having cardiac arrest, and we go up and I manage the airway, and then I walk away and go back down to the operating room and finish what I'm doing. And then sometimes, if you stop to think, or if you talk to someone who's not in medicine, like, "Oh, what did you do today?" "Well, I did a tracheostomy, and then I went and intubated a kid in the ICU, and then did a couple times." It's just like if you stop and think about everything that you do in a day as a physician, it's like, wow. But you can't think of it that way, or it's almost overwhelming. You have to kind of think, just take one thing at a time. And I always tell my residents, do the next thing that's in front of you, and just keep moving. But it does add up, and you do have to deal with it at some point. But there's a right time. It wouldn't serve me to, you know, spend hours, crying over this, thing that happened, or stressing about it, because you have to keep moving. You have to, go on to the next thing. Um, so yeah, you have to learn how to do a little bit of compartmentalization, and then deal with it when you have the space.
So when a resident finishes when a learner finishes a shift with me, 8 to 10 hours or so, sometimes I'll pull them aside and say, "What did you learn today?" And if they learn one thing, it's a touchdown, it's a home run, it's a great day. So for those folks that are listening to this, Dr. Abby Nolder, what are the one or two teaching points or things that you learned about this case that we can summarize and share with the audience?
So I mentioned in the beginning that I remember those first conversations, and, sitting down with the families, when we were, making discussion, or having the discussion about surgery. And I think it's important to just remember that, um, what impact is this going to have on the family? How is this going to change, their quality of life? And just remembering that they, are human, and it's not just, a surgery, that you've done a million times. That these are humans, and everything that you do, impacts them. And just thinking about just them, and the thought processes and things that they have. And just remembering, you know, to be, to show empathy and compassion for them and their child. Um, and then the other is, knowing that, you remember the ones that didn't go well, but you have to also celebrate the ones that do, and not, carry the mistakes, or carry the things that didn't turn out the way you wanted. You have to remember and celebrate the good ones too, because if you don't, then the mistakes and things will kind of weigh you down. And so you have to take it all together, and just remember that you are making a difference every day. And even if you don't get the outcome that you want, you just have to keep moving forward, and, remember the ones that turned out the way you wanted. And, they had 3 years with their child. And, you know, I think that I impacted them in ways, that I don't always think about, because you think about the outcome. But I think, every patient that we touch, we impact in some way. And we just hope it's a positive one.
Well, the last thing I'll say is it was an incredible honor to have you on the show, and I think that the children in Arkansas that are under your care are incredibly fortunate and lucky, and we are lucky to have you, and I feel very honored to be one of your colleagues. You really touched my heart today. So thank
Well,
you so
thank
much
you.
thank you for joining us on the show today. And you had told me before the show that this is a little bit out of your comfort zone, and you're a pro. You are
Oh, thanks.
fantastic.
Well, it's my pleasure. And yeah, yeah, look forward to, seeing you more. And yeah, we're lucky to have you at Children's Hospital too. So glad to be a part.
Thanks for listening to HeMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.